Hello, my name is Lily Nelson, and today I'm going to talk to you about admitting your patient for an anesthetic procedure. This class is for VTHT 1341 for the spring 2025 semester. So I'm going to go ahead and start with your admission record. The patient that I will be admitting today is a 7-year-old female spayed golden retriever whose name is Stinky Grandma, and she is presenting today for a mast cell tumor removal. So I have our admissions record here. And so this gets printed off for our owners, and we go over all of our client information, so their name, their address, their phone numbers, any authorized users, so any of their family members that would be allowed to come pick up the patient for discharge or admit the patient. And then we have the section for our patient information, so it's confirming our patient's name, their species, their date of birth, their sex, their reproduction status, and the reason for their visit today. And so we go over all of this and confirm everything with the owner's information, the client's information, the patient information, and the reason for the visit today. And then moving on from that, we will go ahead and place our owners in a room, and we will begin by obtaining our history. So we actually have a history form that comes with each of our admission record, and it has a nice little outline on the side that just kind of reminds you of the main things that you should be obtaining from your history. For this patient, her history, she has a history of hypothyroidism, and so this patient is currently on a twice daily supplement of levothyroxine to help with her hypothyroidism. Otherwise, she has no prior medical history besides being spayed, but she was spayed when she was at the shelter before she was adopted by this owner. But otherwise, this patient is otherwise healthy, is on monthly HeartGuard medication and flea and tick medication, and has not had any issues prior. And so once we get our history forms, we will now go over our procedure and consent forms. So here's our procedure and consent form. They're not very specific to the procedures. At the bottom here, it states which procedures will be performed. So it's just a general anesthesia, the surgery, ultrasound, radiographs, advanced imaging, or any cytology, histology, or biopsy. And so for this patient, we would talk about general anesthesia, and then we would talk about the surgery, which would be the excision of the mast cell tumor. So with general anesthesia, we would recommend that the patient be fasted 12 hours prior to their surgery. So we recommended this patient be fasted by at least 10 p.m. last night. They received their last meal at 7 p.m. last night. And then for our general anesthesia, there is always going to be risk for aspiration. With the withholding food prior will help decrease for the instance of aspiration pneumonia. And then we also administer Ceridia, which is an antiemetic, to our patients right before they go to surgery to also help decrease in that instance of aspiration pneumonia. And then for this patient, we always will recheck a complete blood count, or a CBC, and a chemistry with lights panel, just so we can look at the hemodynamic status of our patient, but then also look at our organ function for our patient as well, to ensure that our patient would be a good candidate for anesthesia. For the mast cell tumor removal, the soft tissue surgery team will measure a certain amount of centimeters around the actual mass itself to kind of help get clean margins, is what it's called. So we want to make sure that we're getting a wide enough margin that we're taking the bad skin or the mast cell tumor actually out of the patient's dermis. So once they feel as if they have good margins circumferentially for the mast cell tumor, they will do a histology of it, and it will then be graded on what grade the mast cell tumor was. So after our procedure and consent form, and we've gone over that with the owner, that will be signed by the owner and then input in the patient's medical record. And the patient will then be brought back to the back to our soft tissue surgery team. The doctor on the case will perform their physical exam, and then we are a teaching hospital, so we have 4th year students. So they also will perform their physical exam. Then once the students and our doctor are done with their physical exam and we're waiting our blood work results, we will go ahead and put our patient in a kennel in the meantime. So we have a neckband and a cage card. So here's our neckbands. We just have white for just like non-aggressive patients, and we have red ones for patients that would be aggressive. And then what we do is we put our patient's ID number for our hospital and then the patient name and last name, and this would just go around the patient's neck. And then once they're in their kennel, we have cage cards. So this will have the patient ID for our hospital, the patient's name, the doctor on the case, the 4th year student on the case, what the patient is presenting for, any comments. So I put no food, and then if they're allowed to have water. And so that will go with our patient when they're waiting in the kennel before their procedure to be performed. And then our 4th year students and our doctor on the case will begin working on submitting the anesthesia and the OR request. So I have our anesthesia and OR request here that I've printed out. I also have signed into our patient's account. We utilize what's called a VTHT system. So I have signed into my patient's account, and I can now go through here and submit my OR and anesthesia request digitally, because that's just how we perform everything at our hospital. And so again, I printed out the already completed one, and so it states all of the patient's information. It states if this patient has been previously anesthetized at our hospital. It asks about what diagnostics will be performed prior to the procedure. It talks about which procedures will be performed for or under anesthesia. So we're doing a mast cell tumor removal. And then it also just talks about the most pertinent patient history. So their organ status, any prior medical procedures, any prior anesthesia. And then it asks for medications that have been given within 24 hours. Positioning instructions and any other special instructions for our OR team. And then so in addition to our anesthesia and OR request, we would go ahead and submit our CBC and our chemistry with light panel request. So I'm just going to start those and then zoom in on that. And so this is what our online request form looks like. So this is for a chemistry panel. And so it already has the patient information because it's for this patient's account specifically. So the patient information is located here. And then we're just going to select which specimens. So chemistries are ran off of lithium heparins. We're going to select our source. So it's from a venous sample. We're going to collect the date and time that we collected it. And then we're going to say, yes, it is a fasted sample. There is no concerns for zoonotic. And then we are just going to put in our patient history, and then we would select a chemistry panel with lights and then click submit. And so this is how you would do it for both the hematology or CBC as well as the chemistry. So this would be for our CBC panel. So the patient information is located here. We would choose an EDTA for our CBC. We would be obtaining a venous source. We would select the date and time. It is a fasted sample. We have no concern for zoonosis, and then we would input our patient information and history, and then select CBC. And so that's how we would input for our blood work request. And then we would not begin anything on our patient until we got our blood work back, just to ensure that there's nothing that is abnormal and everything is functioning correctly and all of the values are within normal limits. But once we get our blood work back, then our anesthesia team will start developing our anesthetic protocol. So here is our anesthetic protocol sheet. They are blank. You will begin filling out your patient information once your patient's blood work has been brought back. And so just kind of zoom in on this. We have a section for our patient information here, the patient weight, and then our anesthesia team will go based off of the ideal weight if there is an obese patient or an anorexic patient. They will then assign an ASA status to the patient, And then we will kind of just have the morning's vitals on here. And then we will begin by listing the summary of our anesthetic concerns for this patient. And so for this patient, there's always a risk of hypotension with any anesthetic procedure just because of the inhalation gases that are used. There's also always an instance for hypothermia for any anesthetic procedure because anesthetic gases and anesthetic drugs can decrease the body's internal temperature, but then also having the body open on the surgery table can also increase the instance of hypothermia as well. And then because this patient has not had any prior medical issues, she is a healthy 7-year-old dog. I would not expect any other concerns at this time other than hypotension and hypothermia. Well, I guess that's incorrect. I would actually add on, because this is a mast cell tumor, I actually would add on possible risk of anaphylaxis or allergic reaction because the mast cell tumors can actually cause that. And so I did not mention prior, but this patient would also receive a dose of diphenhydramine before going forward with her procedure to help decrease the instance of having an allergic reaction during her removal of her mast cell tumor. All right, and then after our anesthetic concerns, we would move down to our pre-medication section, and then we would have our induction drugs or our anesthetic drugs. And then any post-induction drugs, so these are going to be like drugs that we would take into the OR with us in the instance that our patient becomes hypotensive or bradycardic. So we at our hospital like to take glycopyrrolate a lot and give that to our hypotensive patients. So our anesthesia team may go ahead and calculate a dose for glyco, and they may just bring it with them into the OR. And if the patient needs it, then they can administer it at that time. And if the patient doesn't need it, then it can be wasted in the drug system. So then we're also going to go ahead and add on any CRIs that we may want during our procedure. So any analgesia, or hopefully not, but any pressors that may be needed as well. And it's also, there's a section for local or regional blocks. For this patient, they will not need a local block just because of where the mass is located. And then we also are going to go ahead and calculate our maintenance anesthetic gas rate that we want during our procedure. We're going to go ahead and calculate and determine our flow rate for the first 15 minutes and then throughout the procedure. Our tidal volume, we're going to determine our ET tube size, what size circuit we need, and what size breathing system we're going to want, and then also the reservoir bag size. And then once that has been determined, we're going to go ahead and calculate the IV fluids that we want throughout our procedure and put them at the bottom. And then at the bottom, we also just have any additional monitoring. So if that service may want an additional catheter for any additional supportive care, an arterial line to measure invasive blood pressures, maybe a blood glucose if the patient were hypoglycemic or maybe a diabetic patient, any NOVAs or things like that. And then we also have our post-op analgesics or sedatives. So if your patient may be expected to be dysphoric or painful after surgery, we can already have a dose of analgesic or a dose of sedation already written and ready to go for that patient. And at the very, very bottom of our form here, it says, has the math been checked by at least 2 people? Have you double checked your blood work? Does this patient need blood typing? Do you have your emergency drug sheet, and have you obtained your ECG? And then it has to be signed off by the technician and by the anesthetist on that day as well. And so once we have our anesthetic protocol developed, we will now obtain the patient and begin our anesthesia protocol. And so once the patient has been brought into anesthesia, we will then begin our anesthetic record. So this is what our anesthetic record looks like here at our hospital. It's pretty intimidating, I'm not gonna lie. It can be a lot, but we'll kind of go over it. So here at the top, we have our case information. We have our procedure that will be performed, our patient weight, the ASA status, any of the monitoring that will be required for this patient. We have a blood work section for the blood work, basic blood work results from that morning. We have a section for the IV catheter locations of the patient. We have a section for the pre-medication drugs that were given and administered at what time and which route, and what effects that they brought onto the patient. We have our induction drug section, which induction drugs were given, the amount, the time, and what effects they had. And then here on the side, we have our induction. So it's gonna have the size of the tube, where the incisors were located, what time, and whether or not it is an armored or uncuffed. And then here at the top of our anesthetic record is we are going to have the times here at the top, and they're all in 5-minute intervals because we record vitals every 5 minutes on our anesthetic patient. So here in this section is gonna be our fluid and CRIs that our patient will be on during the procedure. This section here is going to be our inhalant gases and what % they're at. And then right below that is going to be where we start putting our event codes. So those are going to be, for example, patient was induced, patient is now getting wet prepped, patient is now rolling to the OR, patient is now getting drag prepped. So that's what the event codes mean. And then after the event codes, we actually have where we're going to now start recording all of our vitals. And so for every anesthetic patient, you're going to record your heart rate, your respiratory rate, your blood pressure, your temperature, your SpO2, your end-tidal CO2, and then we record your peak inspiratory pressure as well. And then here on the right side, underneath where we recorded our ET tube size, we then record what position our patient was in while they were getting their procedure. And then kind of on the bottom is we have a section for blood gases or NOVAs. So if a NOVA was ran during the surgery, we could put those values on there for future reference. And then we also have a section for any local or regional blocks that were given to this patient. There's a section to put that information here. And then we just have a giant box for any comments that were made. So this is where you put your comments and event codes there kind of and talk about things that were done. So for example, if the patient became hypotensive and they needed a fluid bolus, then you would put a comment number here, number 1, and then you would put number 1 here, and then you would explain number 1, patient was given 10 ml per kg shock fluid bolus of LRS for hypotension. And then here on the right side again, we then have our recovery boxes and post-extubation. So you can determine whether or not your recovery was uneventful. And then for post-extubation, we want to record our time, the patient's temperature, heart rate, respirate, and SpO2. And then at the very, very bottom, it has a spot for the 4th-year student to sign, the anesthetic technician to sign, and the anesthetist on to sign as well. All right, and then once our patient has fully recovered from their surgical and anesthetic procedure, and they are ready to be discharged, we'll go over our discharge summary with our owner. And so each of our discharge summaries has all of our patient's information. So this is gonna have our client information, the patient information, what day the patient was admitted, what day the patient was discharged, any recheck dates, and then the clinicians and students that were working on this case. This will then just have the presenting complaint. So the patient presented for a mast cell tumor removal. It will have the complete history. It will have our physical exam that we obtained that day, any diagnostic tests, so the results of our CBC and chemistry that we performed, and then the diagnosis of what occurred. So we had already previously diagnosed the mast cell tumor, but we did a removal today. And then we just talked about the actual procedure that was done. So it kind of just talks about the treatment that was performed. And then we will begin going over medications to go home and any exercise or diet restrictions, and then things to look out for. So Stinky Grandma will be discharged today for a mast cell tumor removal. She will be discharged with carprofen, which is an NSAID or a non-steroidal anti-inflammatory drug. We highly recommend giving carprofen carprofen is an NSAID or a non-steroid anti-inflammatory drug. Carprofen is typically given for pain and inflammation post-op procedures. And so we recommend giving 1 tablet every 12 hours for pain and inflammation. Carprofen is recommended to be given with food, or it needs to be given with food, because if not, it can actually cause GI ulcerations. And so that is a big concern. Stinky Grandma is also already prescribed levothyroxine for her hypothyroidism, so we are going to recommend to continue giving her levothyroxine twice a day, 1 tablet twice a day. And there is no contraindications that I'm aware of or that I could find on plums about giving carprofen and levothyroxine together. And then we will also recommend giving Benadryl for the next week or the next week to 2 weeks, just to ensure that there is no allergic reactions, or if they did not get clean margins for her mast cell tumor removal, it could actually help with that case as well. So we will talk about incision care because Stinky Grandma had a mast cell tumor removal. Thankfully or fortunately, the mast cell was not very big, and so there's a small, about 3 meter incision, or 3 centimeter incision underneath the left ear. And so we are going to recommend that the owner look at the incision daily. And so we're going to be monitoring it for infection and dehiscence. And so we're going to be concerned for any redness, warmth, swelling, any kind of discharge, whether that be hemorrhagic or bloody discharge, any kind of pus discharge, any odor. And then we're also going to be looking for any kind of separation of the sutures in between the skin. We're going to recommend that Stinky Grandma not be bathed for the next 2 weeks in order for that to heal by itself. And we're going to recommend keeping the incision dry as well. And then for her exercise restriction, we're gonna recommend that for the next 2 weeks, she be limited activity-wise, so that way she does not pull or cause any strain on her sutures. We also wanna make sure that she is not scratching or trying to bite at the incision site as well. We will be sending home an e-collar to help protect that and to keep her from having any kind of scratching or excessive motion to the incision site. We're also going to recommend icing the incision site for the next 3 days, just 2 to 3 times a day for about 10 to 15 minutes to help with any inflammation occurring at the site. And then for her diet, we recommend her, Stinky Grandma, just continue on her daily diet. There is no need to alter her diet in the meantime. And then other than that, just some of the things to look out for, be concerned for, to call us back at the hospital. If you do see any kind of redness, swelling, inflammation, heat or odor coming from her incision, please call us and we can kind of get something set up for her. If Stinky Grandma has any instance of vomiting or diarrhea, we would recommend calling us to talk about what's going on. And then if Stinky Grandma actually shows any kind of facial drooping, any lack of facial sensation or inability to drink on the left side of her face where the mast cell was removed, and this could be an indicator of any kind of nerve damage that may have occurred during the procedure. Restraints for obtaining our blood samples. So I'm gonna go ahead and just start demonstrating for a jugular blood draw. So typically I just like to have my pets or my patient in a sitting position. And then what I'm going to do is I'm going to take my thumbs and kind of place them behind her ears. And then I'm going to take my hands and put them kind of at like a triangle, and I'm going to grab her chin from both sides. And then for the patient drawing blood, I'm gonna hold her this way. And so you can also do another way is you can actually hold their head in between your fingers, and you can actually hold their front limbs too if they start being a little bit unruly. But typically I like to go for an under the chin and kind of behind the head to help secure her head. And then the person drawing blood would just be able to hold off at her thoracic inlet and then draw blood that way. In order to obtain a cephalic blood sample, then I would just sit my patient in a sternal position. And then depending on which leg, I would just make sure that I hold my patient under the chin, and then you want to extend the leg and hold off and kind of roll the limb. And so this would be another example of how to hold a patient for a cephalic blood draw. If the cat was to get unruly, then you could take a towel and you could wrap her up in a towel to secure her limbs. And so that could be a way. And then for a saphenous blood draw, for felines, we typically go for the medial saphenous. And so we're gonna put our patient in a lateral recumbency. Good girl. And we're just gonna put her in lateral. And then what I'm gonna do is I'm just gonna take my hands and I'm gonna grab both sides of her limbs at the elbows. And I'm gonna lay her in. This is going to be a right lateral recumbency. And then I'm going to take my hand and I'm going to push her top left leg up, and I'm going to karate chop her bottom limb. And then the person drawing blood would then grab this bottom limb and pull her leg out and then access the medial saphenous that way. So I have a slip lead here. I'm just going to go ahead and open my slip lead up so that way it's a nice big hole for my patient's head and neck to fit through. So I'm just gonna go ahead and just gently open the door. And I'm now just going to slip the lead over the top of the head, tighten it, and let the patient out of the kennel. Now when you're placing the patient back into the kennel, kind of the same thing. You want to open the door, good girl, and then just take the slip lead off and make sure the kennel is nice and secure. You want to make sure that the muzzle appropriately fits your patient. You want to make sure that the patient is not able to open their mouth to bite. You want to make sure that when you choose your muzzle, that your muzzle works appropriately, is able to clasp appropriately. And so before I apply it to my patient, I just want to make sure that I let out, so that way it's nice and loose and long. And so when you want to apply it to your patient, you want to kind of come behind your patient and kind of underneath in a swift motion like so. You want to secure behind the ears, clasp it, and then you want to make sure that it's nice and tight and that your patient is not able to open their mouth or get it off by sliding or it being too loose. And then you can just take it off, like so. Typically we go on a size variation, and then also depending on if the patient will be going home with this e-collar or if it's just going to be utilized for patient care and technician support in the hospital. So these are the ones that we just typically keep in hospital for unruly cats. And so you just want to make sure that it's going to be an appropriate size that's going to fit around your patient's neck. Not too snug, but also not too loose. So I think this will fit her neck appropriately. And so typically for cats, what I like to do is I kind of like to go underneath and around this way. And then you want to buckle it behind their head. Good girl. You're okay. Good girl. And like I stated earlier, you want to make sure that it's not too tight and not too loose. So I have my two bottom ones buckled. Before I do the top, I just want to make sure that I'm able to slip 2 fingers underneath comfortably. And so I am able to do that. And so now I'm just going to make sure that I secure the top portions. And so just to make sure that it's correct, I usually like to just do a nice little tug over the ears to make sure that it's not going to come sliding off. Start by looking at her mucous membranes. So I'd actually say that her mucous membranes look a little injected. She is moist. Her CRT is about 1 to 2 seconds. With your ears. Good girl. Nodes. Now we're going to listen to her heart rate. her mucous membrane, we've already gone over her mucous membranes. She has no murmurs that I can auscult. Her heart rate was around 88 beats per minute. Her pulses were strong and synchronous with her heart rate. Her respiratory rate was around 30. Her clear lung sounds bilaterally. Alrighty, and her temperature was 101.9. All right, so based on this patient's physical exam and their vitals, with everything being in normal limits, based on this patient's history, this patient does have a history of hypothyroidism and is currently on levothyroxine to supplement that. Otherwise, she has been a happy and healthy pet. She is up to date on all of her preventatives and vaccines. And so based on the fact that she is presenting for a mast cell tumor and she does have a history of hypothyroidism, I would assign her as an ASA grade 2. And some of the abnormalities that could be found, she could have any kind of tachycardia, she could have bradycardia, she could have any kind of abnormalities or arrhythmias noted, or any kind of heart murmurs noted. She could have pulse deficits as well. If any of those are noted, you're typically going to obtain an ECG so that it could be looked at, and you may also obtain some blood pressures as well. When looking at her mucous membranes, they could be injected, they could be cyanotic, they could be icteric. Based on those, may alter the blood work that we recommend. You may end up doing a full chemistry panel with electrolytes. You may end up doing a full hematology complete blood count. For some of the geriatric patients, they may want to send out for full chemistry testing, like I said, with electrolytes, to make sure that all of the patient's organs and electrolytes are within their appropriate range. They may also want to take any kind of additional radiographs, thoracic or abdominal, depending on if they heard any abnormalities on their lung auscultation, or if the patient had any discomfort on abdominal palpation, or if the owners noted any kind of vomiting or diarrhea prior to coming in for their anesthetic procedure. I know that I had already done my physical exams on both of the patients earlier, so the golden retriever Stinky Grandma and then the tabby kitty cat Pickle. For Stinky Grandma, I believe that I initially gave her an ASA grade of 2, but I actually wanted to touch base on that a little bit further. Kind of thinking more about her case, I actually elected to increase her ASA grade to a 3, just due to the fact that she is coming in for a mast cell tumor removal, and there is a possibility that that could disseminate post-operatively, and so that could actually contribute further to her comorbidities along with her hypothyroidism. So I'm just gonna start by assessing her mucous membranes and her CRT. Good girl. I'm just looking at her eyes and her ears. Good job. Good girl. Feel her lymph nodes. All right, we're gonna auscult the heart. All right, so now we've ausculted the heart, and I've made sure that I listened to the heart while also assessing her pulses to make sure that there's no pulse deficits. I'm gonna go ahead and start listening to her respiratory tract. Alrighty, so her heart rate was around 192 beats per second. Her pulses were strong and they were synchronous with her heart rate. Her respiratory sounds were pretty clear bilaterally. I did not hear any kind of crackles or wheezing or any muffled sounds or anything of that nature. Her respiratory rate was around 36 and her character seems fairly normal to me. I'm not concerned with anything that I have seen with this patient so far. So now we're gonna go ahead and just obtain our temperature.
Oh, I know.
I know. We're doing a great job. Good girl. All right, temperature was 100.8, so normal. So given everything for this patient's physical exam, with the heart rate being normal, her respiratory character was normal, her temperature, her mucous membranes are within normal limits. I did not see anything obvious with her respiratory character. I didn't hear any abnormal lung sounds, no abnormal heart murmurs. Her pulses were strong and synchronous. Her medical history is she's up to date on all of her vaccines. She does not have any prior medical diseases. So for this patient, I would assign an ASA grade 1. Just because she has a pretty clean bill of health. All of her physical exams is within normal limits. Alrighty, we're gonna obtain blood from the cephalic vessel on your canine. So we're going to obtain our blood sample from the canine lateral saphenous. Cephalic blood sample from your feline patient. So I just have a 24 gauge butterfly catheter, a 1 ml syringe, a band-aid, and then just some isopropyl alcohol. So I have someone restraining already. I'm just going to extend the limb and have her hold and roll off. And I'm going to apply my alcohol here. And then I'm just going to separate the hairs a little bit. Please let me get this on the first try. Probably should not have taken that out with my mouth either. All right. And now we're going to poke. Alright, so there's blood in our line now, so I'm just going to go ahead and grab my syringe here. I know, you're being so good. It does not work with the syringe. Not poking in the right spot.
Oh.
Ready. Medial saphenous blood draw on a feline patient. I just have a band-aid here, a 24 gauge butterfly, a 1 ml syringe, and then just some isopropyl alcohol. We already have our coworker here restraining for a medial saphenous, and so I'm just going to apply my alcohol. And then I typically just like to part the hairs so that I can better visualize her vessel. Cut that in my video. Alright, and okay. Alright, so I have blood in my line, so now I'm just going to start pulling.
Let's just pump my off.
And I'm down. databases required for any anesthetic patient would be a physical exam, a TPR. We would recommend a PCV total solids or a packed cell volume in total solids, and that's going to measure your red blood cell count and your plasma proteins within your patient's blood. We would also recommend obtaining a glucose and an ALT or alanine aminotransferase, which is going to look at your liver function. We would recommend a BUN or blood urea nitrogen, and that's going to look at how your kidney is able to filtrate the nitrogenous waste within your patient's body. And those are just going to be the basic databases. But if there were any abnormalities found within your patient on their physical exam or in the history obtained from the owner, then some of the other databases that would be recommended just based on some certain abnormalities. So some abnormalities within your patient would be dehydration, any vomiting or diarrhea noted from the owner, any kind of coughing or sneezing would be abnormal, any tachycardia, bradycardia, any kind of tachypnea or dyspnea, hyperthermia, hypothermia. Any minimum databases that we at our hospital actually do is we obtain an ECG for every single anesthetic patient, not necessarily just our geriatric patients or patients who come in with any abnormal signs. We again do that for all of our patients. So we will obtain a physical exam, a TPR, a full history. We will do those few tests that I mentioned earlier, and then we will also as well obtain an ECG. Any vitals added parameters would also be a cause for asking for more database or more data for your patient. And so some of the additional databases required for kind of vomiting, diarrhea, a lot of those things that I just named would be any kind of, you could do chest radiographs for any kind of respiratory issues or respiratory signs that the patient may have presented. We could recommend abdominal radiographs if the patient is having any kind of vomiting or diarrhea or abdominal discomfort. We could recommend a complete blood count or a CBC to look at their full hematology. We could recommend a full chemistry panel with lights, which would look at all of the organ function of the patient, not just a few tests. We could potentially recommend coagulation testing, which would look at your prothrombin and partial thromboplastin time. Or you could look at your D-dimers or your fibrinogen. Those are kind of the other databases that would be recommended if anything were abnormal on your patient's physical exam or history. All right, so like I mentioned earlier, we did a physical exam on Stinky Grandma. She is presenting today for a mast cell tumor removal from her left ear. So I went ahead and we did our pre-anesthetic workup, so I kind of just wanted to go through that. So we have the patient's name, the weight, the ideal weight, and her age. And then we have our ASA grade here, which I said was a grade 3. We have her temperature, pulse rate, and respiratory rate and her temperament here at the top. And then we just kind of have a line here of just some possible complications that we could foresee happening within her while she's under anesthesia. And then here we are going to have our pre-medications. And so for this patient specifically, I chose methadone at 0.2 mg per kg for our analgesia. I chose dexmedetomidine at a 0.1, at a 0.004 mg per kg just for our sedation. And then I chose diphenhydramine dose at 1 mg per kg given IM to help with decrease any kind of allergic reaction, because she does have a mast cell tumor that we will be excising. So we do not want to cause any kind of degranulation of that throughout the patient. For our induction drugs, I chose ketamine and propofol as an adjunct together. And then we just kind of go ahead and prep like any kind of possible pressors or anything of that nature that the patient may need while they're under anesthesia. And so we have a tendency to use glycopyrrolate a lot when our patients become hypotensive. And so I just went ahead and we wrote up a dose of glyco just in case that we would go ahead and take to the OR with us in the need that we needed. And then I went ahead and calculated our CRIs that we would be utilizing within our anesthetic procedure. So I went ahead and calculated a fentanyl CRI for further analgesia as well as a lidocaine CRI. Went ahead and we chose our anesthetic gas inhalant. So we went ahead and we're gonna go ahead and use sevoflurane. We go ahead and just calculate the flow rate, the breathing system that'll be utilized, what size ET tube we have calculated our patient to have, and then the IV fluids that will be ran during anesthesia. And then at the bottom, we also have just post-operative analgesias or tranquilizers or sedatives if necessary, if that patient were to wake up in dysphoria. And then there's also just room for any kind of additional notes. And so like I stated, this patient is does have a history of hypothyroidism. So we just noted here that the patient's levothyroxine should be given before any kind of pre-medications have been given. So this is just our anesthesia protocol. And then with this, we will actually go to our senior faculty anesthesiologist and we will have them approve this. So I am just going to waste ketamine for our patient that did not need it. So this is our Cubex machine. I'm just going to sign in under my account. Maybe. All right, so now we're just going to search for the patient's name and then the appropriate doctor that's caring for the patient. And then we will go to change waste. We will choose the ketamine that we're wasting. And then we will have someone witness us. Right. And so now I'm just going to put the reason why the patient was not needed. The patient did well with fentanyl boluses. Right, and then we will just mark off how much we're wasting, which is 0.28 mils. I would just confirm that with the person that is wasting my drug.
Yes.
Okay. So then we will put 0.28. Right, it has been wasted here, so then we will just go over here and put it in our waste jar. So we're gonna go ahead and go over the different parts of our anesthesia machine. So right now I currently have a rebreathing circuit attached, and it is currently attached. This is going to be our inhalation valve here, and that's going to be connected to our reservoir bag that's going to hold the oxygen and any anesthetic gases that we'll be utilizing. Here in this port is going to be our exhalation connection port and valve. And then this is going to be our soda line, which is going to absorb any CO2 exhaled by the patient. On the back side of this, it is attached to our scavenger, which is located here. And this is just a charcoal scavenger, and this is going to pick up any kind of anesthetic gases that are left in the breathing system. And kind of following around here. On the front, we have our, this is where you will instill your inhalant, and then here is your knob to set your inhalant to different percentages. Here is your flush valve, your oxygen flush valve that you can utilize to flush your reservoir bag. Here is our pressure valve. It's going to measure the pressure in centimeters of water. And then we have our oxygen flow meter that's going to be able to set our oxygen flow rates to different flow rates. And then here on the back side, we have our oxygen tank, which is connected to a pressure regulator here. And then our pressure regulator is connected to the anesthetic machine here. And then we do have an additional oxygen hose, and this can be directly connected to the oxygen that is supplied to the rest of the hospital. And those are typically connected to the giant H tanks that are typically about this tall. Those are in a separate room that have special keys, so I unfortunately cannot show you guys the big H tanks. But we do have the smaller E tanks here that stay connected to our machines. And you just want to make sure that you're always checking about how much is left in your tanks before you begin your anesthetic event. And then something else that we just keep on our anesthesia machines is our syringe for any cuff inflations. A pop-off valve here at the top. All right. So for the two different circuits, like I stated, this one is a rebreathing circuit, which means that some of the gas and CO2 that the patient exhales may actually be inhaled by him or them on the next inhalation, just because we do have the sotasorb and the scavenger to help absorb those anesthetic inhalants and CO2. Non-rebreathing circuit, it's typically going to be used for patients that are about 7 kgs and under, and it's going to be just a circuit that is going, I don't actually have one to demonstrate, so I apologize. I don't actually have one of those to demonstrate, so we're just going to talk through it. But it's just going to be a shorter circuit that's going to have one end that is connected to the patient's endotracheal tube, and the other is going to have a reservoir bag connected. You're going to have a line that is then connected to that's going to connect to your oxygen source, and then an additional line that's going to connect directly to your scavenging. And so what happens with the non-rebreathing circuits is they actually do not rebreathe any of the gas. The gas just goes straight to the scavenger, and the scavenger pulls out any kind of anesthetic gases. So in addition to our rebreathing and non-rebreathing circuits, we also have oxygen masks. And so typically they have rings that will go around to help better have a better seal around that patient. I just unfortunately was having a very hard time of locating one. But as I stated, there's typically a rubber black ring that will be placed on the anesthetic mask, and then your patient will just be able to stick their little muzzle in there, and it'll just have a better sealant, so that way less of the anesthetic gases are expelled into the room. And then we also have our anesthesia chamber, and so this is for any kind of fractious patient or smaller patients, any kind of exotics or wildlife. You can actually connect the anesthesia machines directly to these ports and then lock it so that way no air escapes. All right, so now we're going to perform a read test on our machine. So you want to make sure that you're connected to an oxygen source. You want to occlude the end of your tube. You want to go ahead and close your pop-off valve. All right, and then you want to flush your oxygen bag. And then you want it to set about 20 centimeters. I'm going to watch our pressure gauge and see if it moves at all. It looks to me like it's holding. So now we will just open our pop-off valve and release all of our excess pressure. Demonstrate how to utilize all of our anesthetic monitoring. So this patient has already been anesthetized and is obviously intubated. So we'll just go ahead and start with endotracheal tubes. So in determining the size for endotracheal tubes, there's a few ways that you can determine it. So you can actually go by measuring in between his nares, and that's a good indicator of his tube size. So his current tube size is a 7.5, and so you can take the end of your endotracheal tube there, and you can just place it in between, and if it fits, typically it'll be a good indicator that it would be able to fit your patient's trachea. Another good way is by measuring the trachea itself, so you can just palpate the patient's trachea and go based on your palpation size. And then once your patient is intubated, in order to assess if the patient has been intubated appropriately, you would be able to scope both sides of the chest to ensure that you hear lung sounds on both sides and not just a single one. And if you hear lung sounds on just a single side of the chest, and that could be an indicator that only one bronchus has been intubated, and maybe your tube needs to be backed out a little bit. Another indicator, if this patient wasn't on a ventilator and was on an anesthetic machine, you could have someone bag and hold and see if the machine has any leaks. And if there are no leaks, then that's a good indicator that there are no leaks in your tube. What we have for our ventilated patients is we actually have a endotracheal tube inflator, so we can actually utilize that to measure the endotracheal tube and determine if it has leaks or not. Alright, and then going towards our monitoring, so we have our machine here connected to everything. We have our ECGs, and for this patient we have the ECGs connected to pads on the right and then on the left side, and it should be reading the tube. We have our SpO2 monitor here, and we have it connected to the patient's lip here, and this is going to monitor the patient's oxygen saturation. And it's just zeroing out. We have our end-tidal lines here, and this is going to measure the end-tidal CO2 that our patient is breathing out. and we want to ensure that it is within the 35 to 45 range. And then another thing that these machines do is, depending on the end-tidal CO2 or the ECGs, it will calculate the respiratory rate. For this patient, he's set at a specific respiratory rate because he's on a mechanical ventilator, so his respiratory rate is about 37. We have that turned off on here, but you can kind of note it here on the side. It says here, airway respiratory rate is 37. All right. And that end tidal is actually connected to our endotracheal tube here, and then screws into this portion, and then gets connected to the side of our machine. And so this is called a side stream endotracheal CO2. And then moving along, we have our blood pressure cuff that is connected to the machine. And so we currently have it on this patient's tail just because all of the limbs have been poked and some of the limbs have some peripheral edema. So we figured that would be the best area for his blood pressure cuff. And this is non-invasive. There is ways to do invasive blood pressure on him, but unfortunately we just were not able to access that at the time. We also have our blood pressures that are going to be read here, and we currently have them set to read about every 15 minutes. You can change that on your computer there. That's just what we have it set for this patient. If this patient were to be under an anesthetic event, typically we measure them every 5 minutes. And then we have our temperature probe that is kind of tucked in with our, we have it tucked in with our blood pressure cuff, but it is currently in the patient. We have a temperature probe on it, and then it is just connected to the machine, and then it's reading our temperature here. And then for our last thing is, for this patient, we're just going to utilize an esophageal stethoscope, and we're going to pass that through the esophagus so that way we can hear our heart and lung sounds. One of the other things that you could do is you could also pass a gastric tube. For the gastric tubes, you're going to want to pass them to the stomach, and that's typically to either get maybe some air out of the stomach or any kind of gastric contents to help empty it out. For the esophageal stethoscope, we're only going to advance it to about the heart base, which is going to be about 28 to 32 centimeters. And then once we've kind of hit our 28 to 32 centimeters, then I will go ahead and listen and see if we are in the appropriate spot. So I'm going to go ahead and just lubricate my esophageal stethoscope for my patient's comfort. We're just going to have someone just gently open his mouth so it's much easier. So we're just going to place a new catheter in the other limb. So I have my coworker here that's already holding for me. I'm just going to clip some more fur because it looks like some of the fur has grown back since her last placement. So at our hospital, we clip circumferentially just to help our tape stick to the patient better. And then now I'm just going to take my ChloraPrep and isopropyl alcohol swab sticks, and I'm going to swab the vessel 3 separate times. And I like to use the front and the back of each one just to help with extra cleanliness. All right, sweet girl. All right, and while that dries, I'm just gonna prep my T-port and get my catheter ready. So I have an 18 gauge here that I have already got ready. And I'm now just gonna take my T-port and go ahead and just pre-flush it with some normal saline. All right, and I already have some tape torn and then all of my wrapping items here. All right, you wanna lay down or you wanna stand, sweet girl? All right. make sure my bevel is pointing up. I'm going to insert my catheter. And I'm getting blood there, so now I'm just going to advance. I'm going to connect the T-port there. I'm going to try and wipe off my hand as much as I can because it's covered in blood. Right, and then we're just going to give it a good flush and have our holder palpate it just to make sure that we know it's in the vessel. All right, so it's flushing well, and she said that she could feel it in the vessel.
It's okay. It's okay, sweet girl. You're okay.
All right, so now we're just going to secure it with our tape. Good girl, Gracie. Alright, now that's taped in, I usually just like to wipe off any blood so that way it's a little bit more clean for our patient. And then we will just start wrapping. Because it's like right above her carpus, I'm just gonna wrap right above that. And then once it's wrapped, I usually just like to give it one more flush and have our holder just check it one more time to make sure it hasn't moved after we wrapped it. All right, she said it's good, so now we will just clamp it off and then we will just date and time it. So we like to just notate what size catheter it was, the date and the time that it was placed, and then just initials because I was the one who originally placed it. Just an orange swab cap on the end. Alright, you're gonna tint the skin up like this, and in the tint, you're gonna insert your needle and draw back to make sure that there is no blood and inject. We're gonna find our nice meaty spot. Alright, you're gonna inject it, and then you're gonna wanna pull back on your syringe to make sure that there is no blood, and then go ahead and inject. Alrighty, we're going to give an intravenous injection for our canine patient. Okay. You're going to draw back to make sure that there is blood in your syringe, and then once you see blood, you can go ahead and push the medication. So we are just having our coworker here go ahead and start just slowly titrating our propofol so that our patient can go ahead and start kind of going down to their anesthetic depth. We have our tube already prepped and ready. The end has been lubricated. We have our eye lube ready. We have our gauze tie, our tongue gauze, and our laryngoscope ready for when the
Good boy. We need to pull him more forward for you. We can
right, you can work with whatever.
You just want to scoop that tongue out a little bit for me? Perfect.
Alright, so we're just going to take the laryngoscope.
Oh, big yawn. I might give him a little bit more really quick because he's still kind of stiff for me. Maybe that yawn was him settling in.
Alright, and with the laryngoscope, you're just going to gently press on the base of the tongue to kind of get the epiglottis to come down.
If he continues to cough, I can give him more. Beautiful. And then for us, I'll have us get him connected before we tie him in. Our student will go from here. We're going to turn on his oxygen as our tomo procedure.
Okay. Alright, so we went ahead and connected his oxygen.
You want to give him a breath? We'll see if our...
And so now we're just going to take our puff cup and we're going to listen. So it definitely sounds like there's some leaks, so we're just going to insert some air into the cuff. I think 2 mils is good, or
Yeah,
less.
I think 2 mils is good. It sounded like a large
We
leak.
added about 2 mils, so we're going to check again. I still hear a little bit of a leak.
I might start with like a mil.
A mil?
That one sounded
Okay.
smaller.
We're going to add another mil.
I didn't hear anything.
I do not hear
Great.
anything either.
Okay, we can go ahead and start his gas at 2. And then I'll hold his tube here and keep his mouth open while you...
So now we're going to tie the tube.
Hey, Gabby. Will you let me
Right, I'll
know
have it
what
at
side
1.
his tongue goes on?
Great. And then for this procedure, we're just going to tie it to the bottom jaw because that is...
Give me just a second. Sorry.
I
Can
have one
we
right now,
flip
but
his
what does
tongue
the
to the
green
other
sheet say?
side of his mouth?
45.
Perfect. Sorry.
Don't apologize.
We'll just make sure his tongue is not in that gauze before you really cinch him down. Beautiful. Small gauze. Alright, full. Alrighty. Good job. And our student is continuing to breathe for him.
And so you just also want to just auscultate both sides of the lungs to make sure that both sides have been intubated and not just one bronchus. So if you wouldn't mind just giving some breaths. Sounds good on this side. All right, it sounds great on both sides. I hear lung sounds. And then we will just take our eye lubrication and lubricate the patient's eyes. Good job, friend. We're just going to express the bladder before we take the patient back to the OR.
You're gonna have a skinny piece that's up underneath, right? That's gonna be what puts the handle on the catheter. You're gonna have a fat piece or a skinny piece that stays down underneath. That's gonna be what suspends it into the vessel. Third one is just your choice, but whatever way makes it more secure. I like to say you should not be able to see the color gauge of catheter behind the T-port because it has a lot of, typically that means it has a lot of lateral play. Right, so if you're trying to get under the drape, it's likely that you're going to kink it out to the side, or if she gets swallowing tracing or kennel, she's going to hit it to the side. That's going to kink off.
All right. About all we got.
And so,
All right. For the dry prep shave, I just wanted to mention that you want to shave up about 2 fingers cranial to the xiphoid process, and then all the way down to the vulva, and then on the sides we typically shave all the way to the ankle folds. Now we're just going to go ahead and do our dry prep for this patient's spay. So we have our chlorhexidine scrub here, and we're just going to start.
Okay. 10 minutes for each one.
Middle.
Start out with 60.
That's fine. That much over 10 minutes. So you have to keep on of this.
Oh,
You can.
okay.
Now we're going to switch over to alcohol.
Thank you so much.
You're welcome. I'm here for you, Francis.
Yeah, okay.
Always you. Anything you need.
Different pressure is a bit low, heart rate is high, right? So that's why I trying to be more body.
We're going to do this 3 times, switching back and forth between the chlorhexidine and the alcohol.
Potential cause
Like
hypertension, maybe hypovolemia at this moment.
Oh, the bottom.
No, thinking about the circulation itself, people this gigantic dose. So this organ
Oh,
is
okay.
into in a cover. So pre-roll decrease, that means actual also decrease. So we try to deal with this background difference is already work. It's not working, we need some kind of treatment. So we try that one first. So that's why we're giving chest touch 250 over 10 minutes.
Press your back, stay still. Always protect the weenie dog's back. All right, Lily. On you. There you go. Yep, just like that. Good job. Good. Go ahead and finish getting the rest of your testing hooked up, blood pressures and all that. And then get your Surfazanil when you can.
Okay, so
Also-
you can do it pre-op.
Yeah, yes. I need that sheet. And that sheet.
I just undid it. I'll reattach it just a second.
Corner.
Top right corner of the button.
Oh, this one.
Yeah. Thank you.
Let's see.
So David, on this one, start running here. Your testicles over here. So kind of this area, and then work your way up.
Okay.
And I want these things here to where they're not tangled.
We are just monitoring our feline patient, Jack. He's just here on extractions. He is already under anesthesia, so we're just gonna make sure that we write down his vitals, and we're gonna be recording those every 5 minutes.
It looks like that's tooth, and then this is
And so,
like
yeah,
the whole
we kind of go with different
another
codes,
tooth
and
is
so
actually
based on that is
better.
how we will put it on our sheet. So I'm just gonna go ahead and start with
Yeah,
his
so
heart
don't
rate, which is
skip too much. If you
115.
find it, you can skip that part.
Okay.
Figure it out.
And so for that, we're just gonna do a solid dot. Alright, and his respiratory rate is around 5. So that's an open circle. We have his end-tidal CO2, which is around 35, so that's going to be an open square. And let's see, his systolic pressure is 134, so that's going to be an up arrow. And his diastolic is at 87. And his mean pulse is 95. His SpO2 is 99%. Temperature is 100.2.
And then when I get on this, what you do is I go back to this one.
Ready? And then, like I said, we are going to record those vitals every 5 minutes. Yeah, your patient is under anesthesia. Demonstrate CPR. Shake your patient and see if there's any sign of consciousness. And then you're going to want to check their airway for any sign of obstruction. And then you want to check their perfusion, so their pulse, or auscultate them to see if there's their heart rate is going or their heart is pumping. And if none of those things are happening, then your patient has arrested and you want to begin CPR. So you want to start by interlacing your hands on top of the other. Keep your elbows straight and locked. Keep your back straight. And then you want to start by compressing over the heart. And you want to compress down about 1/3 to 1/2 of their chest. And you want to do this for about 120 beats, 100 to 120 beats, or to the rhythm of Staying Alive, which is what everyone typically knows that for. And you want to do your chest compressions at 2-minute cycles. And then once the 2-minute cycle is up, you're going to have someone switch out with you. And while someone is switching out, you're going to have someone feeling for the pulse to see if there's any sign of perfusion. And then for your breathing, once your patient is intubated, you're going to want to breathe with an ambu bag, and you want to give breaths that are pretty deep, because you want to be able to overcome that person giving the chest compressions. And when you're giving breaths, you want to give breaths about every 6 seconds or so.
I'm a fan of the playlist.
Can never go wrong.
I'm sorry. I don't do this ever.
No, actually excellent. One for the 6.
When Cooper's hands
And
is
our math was like 82.
I know that.
So yeah.
Okay, so you go ahead. Thank you. Sure. Works the hands there. So you can grow.
Yeah, we're reading on our own, and yeah, excellent.
Yeah.
You know,
It's doing great. Excellent.
Our oxygen hose. That's all over our machine. You want to hand that to me.
Or what?
The oxygen to me.
Yep.
And I will connect this to the wall. And then we can turn off our AC. Okay.
Nelson.
We're gonna find out.
Don't turn around.
Don't turn around. You just stop it for a second here. Is it 20?
Yep.
Once you get the other one on, you can like do your adjustment.
Normally what I do for my other one is I will just take a picture and a needle and I'll put it around here. Yes. You know, this is the connector. Can I check this one? Yes. And your last name. NC
That's how my first one was.
LAIN. Okay. I will get it, I promise. That's okay. And then what's your name, Susan?
Stephanie McGuire with an A. So MAGUIRE.
Okay. MAGUIRE. Okay, so what I will do is I put a needle here and I'll just open it wide and I'll just shoot out here. Instead of filling the bubble down to the patient. And that's it. Yeah. But I'm just gonna put it on here. Is that it?
And then hit. Thanks for letting me do this.
You're welcome. No problem. I may be visiting y'all in a few months to in critical care.
Yeah, she's great.
That's the big, like, thing over the handle. Those apples, and those are the little drinks.
I say that as I be
And then you can like let it drop.
I can hand you the next one. Is that okay? Is that okay?
Yeah.
Yeah, so.
Like that. So your middle finger and your pointer finger. There you go. I like to do the peace sign, but
Is this a good?
Yeah, go for it, go for it.
More?
No, we're fine, go for it.
Okay.
Does, the win.
They sit in front of stuff. This will be the fun one.
getting underneath.
Yeah. Pick up his little ball. I guess I can't say that over your video.
Sorry.
You want to pass those two money stuff?
many do you have to do? Just one?
Just one.
You can take your time because we don't need that blade.
Okay.
I like that.
Okay, post are getting ready for ask questions.
Not needed.
Need for ICU fluid order request.
It's done.
Awesome. Anesthesia's antibiotics been given.
Yes, Cefazolin is given 77 milligrams at 10:45.
Alright, so some of the duties and responsibilities of a sterile technician in the OR is you are to help assist with any surgeries, so any kind of blood clotting, any kind of wetting tissues, handing off instruments to your doctor, assisting with the surgeries. Those are kind of big things that sterile technicians do. Kind of another thing is they also do the last prep, typically for the patient once they've come into the OR, because they're already sterile, and usually sterile prep is the last one before the actual surgery is performed. They could also help potentially drape the patient as well, because draping is also done in a sterile manner. Anyone that is sterile were to become unsterile, so like if there was a hole in the glove or if the glove touched something that was unsterile, we would have an unsterile technician or another doctor give the sterile person a pair of gloves, and they would be able to re-don their pair of gloves and be sterile again. If your doctor or yourself as a sterile technician were to drop any instruments while you were sterile, you could do kind of two things. If you have multitude of those instruments or multiple sets of those instruments, you could utilize a already sterilized set and bring that into the OR and open it. Or you could use what's called flash sterilization, where it's just putting it into a sterile solution for a certain amount of time and then giving it back to your doctor.
Brush your back, get still. Always protect the weenie dog's back. All right, Lily. On you.
And that just preps if we have to open up. Look at those little suckers.
If I could go, that'd be the same.
This surgery team just finished up with a patient, so I'm just going to demonstrate how we clean our ORs after they are finished. So pretty much I will start by just getting rid of all of the bodily fluids, so all of our just potty pads and stuff I'll just throw in the bins, and the blankets and things we have hampers for, so I will put that in a separate hamper. And then I'm going to start by picking up all of the sponges and things that are on the floor. And then we used both this light and this larger light, so I'm just going to make sure that I clean those off. the products, once they've been wiped off, back where they're supposed to go. And this is our cautery pad. We cannot use rescue wipes or rescue to clean this off with, so I'm just going to use some isopropyl alcohol and then wipe it off with just some water. I'm just going to wipe these countertops off while we let the alcohol sit. I'm just going to take a dry wipe and dry it off. Alright, so now I'm going to table. surfaces has been cleaned. I'm just going to move some of the equipment back to where it's supposed to go. Alrighty, and then there's just some suture that was not utilized by the doctor, so I'm going to return this to the patient. And while I return this to the patient, I'm then just going to grab stuff to mop the floors with. Alright, last but not least, we will mop our floors. So I have our instruments here that we are going to clean and soak. So I have my InDesign BioClean solution that I have put in our bin here. And I went ahead and opened up all of our instruments with our instruments in here. And so now we are just going to let them sit in this InDesign cleaner for about 5 minutes. And then once it's set for about 5 minutes, then we will take our scrub brushes and start scrubbing and rinsing them off under the water. Alrighty, so our instruments have been sitting for about 5 minutes, and now we're just going to go ahead and start scrubbing them and washing them off and drying them off.
Yeah, so again, they come different signs about, you know, you're talking about, hold on. Yeah. Maybe cut with a blade or even a punch class is gonna be big enough, right? So the biggest issue, I would say, is not crushing it. So don't grab it if you come vortex.
Alrighty, and now we will let our instruments sit and dry, and then we will begin assembling our pack. Now that all of our instruments are dry, we're going to go ahead and start assembling our small wound pack. So I'm just going to take my instruments, and I like to just start from largest to smallest. Alrighty, and I have just a wound tray, and then I have a towel in here, and then my instruments on top. Alright, I'm gonna take my opaque gauze. Alright, and then look at my indicator. Alright, you're gonna take your 6 o'clock piece and fold it over. And then take the left side. And then your right side. I'll bring the top part over. So now we will go ahead and put some of our indicator tape on the section of it. Alrighty, and so now we will just date and time this and label what pack it is. So this is our small wound pack. Alrighty, and so now we will take this and put it in our autoclave. We're going to take our sleeves and we're now going to fold them in. And now I'm going to take this right side and fold it about halfway. I'm going to take the left side and also fold it about halfway. Alright, so now that they're both folded about halfway, I'm now just going to completely fold it in half. Alright, and then we're going to fold it in half again. I'm going to start accordioning the bottom of the gown. All right, and then we will take our towel for our doctor to dry their hands off with once they are sterile, and just place it on top. Take our indicator strip and place that on top of the towel. All right, and then we will take our wrap here, and then just like previous, we'll start at 6 o'clock. At 3 o'clock. And the last one. I take our sterilization tape and place it on our gown pick. Alrighty, and then just like the first pack, we will label this as large gown, and then where it goes, today's date, and the initials of who did the gown pack. Alright, and this would be our gown pack. Alrighty, so now we will just take our pack down to the autoclave, but before that I just want to talk about how our autoclave works. So an autoclave is actually a high pressurized chamber system, and it utilizes high temperatures of pressurized steam to kill off microorganisms. And typically autoclaves can reach anywhere from 250 to 270 degrees Fahrenheit, and this high pressurized steam at that temperature will help kill off any microorganisms that were not killed off in the cleaning and scrubbing process. Alright, so this is our autoclave. It's very big, but here's our wound pack. This is the stand that we're going to set it on. So this is our that we're going to push into the autoclave. When you're putting the packs in the autoclave, you want to make sure that you're not stacking them on top of each other. You're making sure that there's room for the steam to kind of flow in between the different packs. And so now we'll just insert this into the autoclave. Industrial autoclave. So I just came back upstairs just to further talk about how to properly set the autoclave, just because it is very loud downstairs. Small wound pack specifically, we're going to set that at around 250 degrees Fahrenheit, and then we're going to set that pack in there for around 30 minutes, and it's going to reach about 15 psi. So some of the upkeep that you need for your autoclave, there's daily, weekly, and monthly upkeep. Every day we typically wipe down the inside and outside of our autoclave doors. Every week we will wipe down, and we just wipe the doors just with a damp towel. Every week we will clean the inside of our autoclave with a damp towel and just some Dawn dish soap. And then every month we will empty our water reservoir in the autoclave and refill it with fresh distilled water. So I now have our instrument pack back from our sterilization, and just to show you guys, so we now have the black stripes on our tape, and that is going to show us that this passed our steam sterilization. And then we also just have little stickers that our OR team puts on here, to say that it has been sterilized and it has the date and the time. And so that is on there. We have our black stripes to prove that it has been sterilized appropriately. And so this would pass the sterilization. Remove these sutures from Blaze today. And in order to determine whether or not the sutures are going to be removed, it's typically going to be about 7 to 14 days after the surgery or after the wound care has been performed. And you want to make sure that there's no redness or swelling or discharge coming from the suture site. And you want to make sure that the skin has come together nice and snug. Right. So.
What's the second one with that? Convinced of and they've done it like one body to out. They have like 2 cases that ended up dying. Yeah. And then who was? Hey, I think it's a CT. Oh, yes. So they ultrasound the dog, the ultrasound, and the form body is fine. Great. Go back to
Alright, what? Alright, do you need help with appointments? No. I was kidding. We don't have an intern.
Yeah.
Where's your intern? She's she requested to be off.
Yeah, thank you.